So Kathy's talk was a good prelude for mine. So first I want to ask, are there any cardiologists in the audience? Good, because I'm a pulmonologist talking about cardiovascular disease. I know the literature pretty well, but you know, digging deep into the clinical side of cardiac disease is not necessarily where I'd want to go. So to move forward. So Kathy's talked a lot about particulate matter. What is it? But I have a couple slides in this regard. I probably normally wouldn't have put in regulation for this talk, but given the fact that the Clean Air Act and the National Ambient Air Quality Standards that flow from that, and EPA in general are under attack, I thought I should just mention how we regulate particulate matter. A little bit about how particulate matter, air pollution factors into the global burden of disease. Kathy's talked about the integrated exposure response. It's perfect setup for how I will talk about it. And then most of the talk will be about PM and cardiovascular effects. I'm going to concentrate on epidemiology and that part, and then biological mechanisms, the mixture of animal and epidemiologic research. So particulate matter, just to refresh everyone, different than the other types of criteria air pollutants that EPA regulates, is not regulated by chemical composition, it's regulated by size, as Kathy pointed out. So it can have origin from a variety of sources. And just taking ambient particulate matter, there's combustion products, often thought to be more toxic, but there's a lot of evidence that the larger PM10 to PM2.5 so-called coarse fraction, which contains a lot of biological material, is very active as well. And so ultrafines, definitely an important source is fossil fuel combustion. This fine particles, PM2.5, again, fossil fuel combustion. The coarse fraction, the particles between PM10 and PM2.5 in ambient air, there's a lot of road dust and crustal material and biologically active material like pollens. Kathy's talked about size, but I love this slide that compares these different size fractions to human hair. So these are to scale, so you can see that the ultrafines are very small.
Thank you.
And can translate.
That's super helpful.
I try. And then Kathy's gone over this, so I won't spend time, but just to remind you that the different size particles make it into different areas of the respiratory tract, from the head region to the tracheobronchial region to the deep lung. And the ultrafine particles, as Kathy said, can translocate into the systemic circulation. Now, I'm kind of surprised that Kathy didn't talk about diesel exhaust because she's an expert in this, but that was good. She left it for me. So, how often do you see this kind of smoke coming out of diesel trucks in California anymore?
Still more often than I'd like.
That's an appropriate answer, but compared to anywhere else in the world, we're way ahead in controlling this. You could report somebody like if you saw this on the freeway. So diesel exhaust isn't just particles. There's also irritant oxidant gases, which I'm not going to talk about. But the particulate matter, diesel exhaust particles have a carbon core with complex chemistry on the surface. And those chemicals on the surface, those hydrocarbons, are known to cause oxidative injury to cells, and that can lead to inflammation in tissues. Again, I'm not going to spend a lot of time on this, but this is really going into some detail about the materials that are absorbed onto the surface of the carbon particles. So it's not just soot. It's also soot with metals, with complex hydrocarbons that are known to be toxic in animal and cellular studies. And just to remind you that, nationwide, diesel emissions are a major contributor to fine particulate. And in some places, some cities, it's 10 to 20% of the total fine particles. In California, we've done a lot to deal with on-road diesel emissions. We've been less good about off-road agriculture and construction, though we're trying. And nationally, there hasn't been as much movement in terms of reducing diesel emissions as we've done in California. So Kathy alluded to biomass smoke from household combustion for cooking and heating, especially in the developing world. I'm not going to go into detail about this, but as Kathy pointed out, like occupational exposures, these are in between secondhand tobacco smoke, ambient air pollution, and active smoking in terms of the total amount. And if you look at what comes out of cook stoves, burning wood, or other biomass material, it isn't that much different than tobacco smoke, or even for that matter diesel exhaust, if you want to be a lumper. It's just that it doesn't have nicotine. So you don't get addicted to household air pollution the same way you get addicted to tobacco smoke, but they're somewhat similar in terms of their chemical constitution. So, a little bit about air quality regulation in the US. I hope most of you know this, but the Clean Air Act, the initial version started in 1963, but it wasn't really until 1970 that the US EPA was started to enforce the Clean Air Act and come up with national ambient air quality standards. So, many of you weren't even alive in 1970, but it's important to remember the Clean Air Act and the US EPA were started with a bipartisan majority. We had a Republican president who signed the bill. There was a national consensus that we needed to clean up our air and water. And what came out of the Clean Air Act was this notion of a criteria pollutant. And this is a pollutant for which there was enough scientific evidence of health effects that we should regulate ambient levels, the concentrations that we all breathe. And these are called National Ambient Air Quality Standards. And they're supposed to have, this is a very important concept in today's world, an adequate margin of safety to protect the most susceptible groups. This is written into the Clean Air Act. It's law. So that means that whenever science shows that there are health effects and those health effects can be confirmed, the ambient standard should be lower than that. So, what scientific evidence is used? I'm going to be talking about these types of evidence. Epidemiologic studies, which have the benefit of having the right species. It's us. A major problem is it's hard to isolate a single pollutant from the air pollution mix. Controlled human exposure studies, again, the right species, but these are experiments that can be dangerous. They're increasingly hard to do because we're not supposed to do harm to our subjects. But when they are done in the context of specific pollutants, they're very powerful because it's experimental data. And then animal toxicologic studies, you can do much more. I hope I'm not offending anybody, with animals than you can with humans. But then there's the issue of cross-species extrapolation. So, I'm going to charge into, before I charge into, I'm going to just start off with a little bit about our current regulation of particulate matter. PM10 is only regulated at a 24-hour basis now. Just to put this in perspective, Beijing and Delhi are over 150 micrograms per meter cube over a 24-hour period for days, weeks, potentially months at a time. The last time we got to these levels in California were related to major wildfires, like the Rim Fire. And actually it was Reno that got 180 micrograms per meter cubed after the Yosemite Rim Fire, rather than California location. But I want you to focus on the PM 2.5, the fine particulate. 12 is the micrograms per meter cubed is the annual average, and 35 is the 24-hour average. Because I'm going to show you some data that will question whether these are adequately protective. So the reason we have a PM 2.5 standard is there are multiple studies before the late 90s, when the PM 2.5 standard was promulgated by EPA, that showed an association. There were time series studies. So time series, there'd be daily levels of PM 2.5, and then you could just count how many people show up in the emergency room or how many people die on a given day. Here it's mortality, so how many people die. And there are multiple studies that show this association. It's very robust. But it wasn't really until you had several longitudinal studies published that linked chronic exposure over many years and mortality, where there could be better control of potential confounders, that the EPA felt there was enough evidence to act. And while I'm sort of on my semi-political rant here, I'll just say that the law, or excuse me, the EPA regulation for PM 2.5 that was promulgated in, I think, 1997, 1998, it was challenged in court by the American Trucking Association, went all the way to Supreme Court. Supreme Court said that EPA was within its responsibilities and rights to promulgate this. Who was the author of the majority opinion in the Supreme Court? Anton Scalia.
Wow.
Just to say, we've come a long way since then. So this is the study that really put PM and mortality on the map, the so-called Harvard Six-City study. And here we have Portage, Wisconsin, a very clean city, and Steubenville, Ohio, at that time, heavy steel mill city. And there's a beautiful linear relationship. This is rate ratio in terms of mortality, and then on the x-axis, fine particles. You know, the current standard is right here for annual average. This was a study in the early 90s. Now, a lot of progress has been made in terms of cleaning up the ambient air in terms of particles. And this was a study done many years later, published in the New England Journal of Medicine, like the last one. There aren't that many air pollution studies that get published in the New England Journal. The ones that are published are the impactful ones, like that Six-City study. And this study showed that with reduction in PM from I think that's 80 to 2000, there was an improvement in life expectancy across the country. And every one of these circles is a different city. But overall, as we've improved the levels of PM 2.5 in our ambient air, there's been an increase in life expectancy. And this is controlled for a lot of other potential confounders. So I guess the message there is the Clean Air Act works in terms of its mission of trying to protect public health. Now, Kathy showed a different version of the exposure response in terms of cardiovascular mortality in this case and combustion particle doses, but it's worthwhile reviewing. So down here we have ambient air pollution epidemiologic studies. Then we have secondhand tobacco smoke epi studies, again with cardiovascular mortality. I should say one of our later speakers is a co-author of this paper, Michael Jarrett. At least the original paper. This is Kirk Smith's replication of this dose response curve. And this is active smoking up here. And Kathy showed you this area where she would put occupational exposures. It was beautiful to see that filled in. And it's also where biomass smoke fits in. And it's important because we don't have very much epidemiologic data with regard to cardiovascular mortality and household air pollution. And we need those data, but until we get those data, we can use the so-called integrated exposure response curve to estimate what we'd expect if household air pollution particles are as toxic as other combustion source particles. And this is important for the global burden of disease studies, and these are done periodically to try to come up with a comparative risk assessment of various factors that impact public health around the world. And air pollution is number 5, and this is ambient air pollution and household air pollution. I don't believe occupational exposures are in this air pollution. Their occupational exposures are down here, which include things other than inhaled particles. So you can see that worldwide, exposure to particulate matter is an important driver of health. So now let's dive into what we know about particulate pollution and cardiovascular disease. Now this first slide is from a paper that reviewed the literature on air pollution exposure in general and cardiovascular disease. There are effects of these gaseous pollutants, but this review, and it's my assessment of the literature, suggests that it's really particulate matter that's the big driver of cardiovascular events. Again, I'll mention Mike Jarrett. He's going to come up repeatedly over the course of this talk, has shown that ozone has mortality effects as well, but this talk is about PM. So from that same review, Newby et al. Is this somewhat complicated slide showing the pathways by which air pollution, and you can just put PM there, might lead to cardiovascular morbidity and mortality. And there are effects on atherosclerosis and rupture of atherosclerotic plaques. There are direct endothelial dysfunction effects, which Kathy mentioned to some extent, vasoconstriction of arteries, clotting of arteries, and then arrhythmias. And we're going to talk more about this. So this American Heart Association statement was really a landmark in my view, because this is when cardiologists sort of took up the mantle that us pulmonologists were taking up for a while about air quality. And it was really important, I think, in terms of getting the public and the public health sector aware of how important air pollution could be as a contributor to cardiovascular disease. You know, it was long felt that inhaled pollutants could affect the respiratory tract, but it was later that we learned that perhaps impact of inhaled particles and other pollutants on the cardiovascular system had potentially more public health impact. And when they published this paper in 2004, they based their recommendations that cardiologists be aware of air pollution exposures on the fact that there were multiple population-based studies from all over the world that showed associations between cardiac mortality and high levels of particulate matter. And that was mortality. There was also morbidity data with regard to hospital admissions for acute coronary syndrome or angina and acute myocardial infarction. And finally, at that time, there was a very sort of high-quality study that linked levels of PM in Boston, so not Beijing or Delhi, with an increased risk of MI. And here are some more recent data from a meta-analysis in 2014 showing all-cause mortality, cardiovascular mortality, specifically the subfraction of cardiovascular mortality is ischemic heart disease, then there's stroke. These two would be together under cardiovascular. And just for reference, respiratory and specifically chronic obstructive pulmonary disease. And so this was a systematic review of the literature and meta-analysis showed fairly convincingly that there was a lot of data to support the fact that PM 2.5 is associated with cardiovascular morbidity and mortality. So a little bit about stroke. That same greater Boston area group from Harvard studied the short-term exposure to PM and risk of ischemic stroke. There's different kinds of stroke. There's embolic stroke and ischemic stroke. Ischemic stroke is similar in the brain to what happens with a heart attack. And this is showing as you increase your exposure to particulate matter, there's an increased risk of stroke. And the onset was most strongly associated with traffic-related PM exposures 12 to 14 hours before the event. And so we're talking, here's PM 2.5, but here's the black carbon fraction of PM 2.5, which is thought to be a reasonable surrogate of diesel exposure. And there's residential exposure, and then there was sort of total black carbon exposure. So this is a study from Canada. I think Mike Jarrett's on this one. I told you his name would come up a lot. And this study looked at cardiovascular disease, ischemic heart disease, stroke, and you can see on the far right, hopefully, that adjusted for both ecological covariance and whether the person lived in an urban area or rural area of Canada, that actually strengthened the associations to do that adjustment. And here's the exposure response for PM 2.5, member 12, and risk of ischemic heart disease. And as Kathy pointed out quite correctly, there's a steep portion of the curve and then it flattens off. But it flattens off at a pretty low level. So, using her very eloquent discussion of this topic, it's really on the steep portion of the curve where you can have your most public health impact. So there are these quasi-experimental studies that have been done. I'm just going to point out a relatively recent one, which was related to the Beijing Olympics. Probably most of you know that Beijing is a very polluted city. In order to host the Olympics, the Chinese government, because they can do this in China, had some very strict policies that were put in place in terms of motor vehicle traffic, and they shut down a bunch of dirty industries, relocated them. They actually seeded clouds to get rain. They did a lot of things to reduce PM exposure, and it was reduced during the Olympics. And this group, primarily from Rutgers, showed that with the decreased PM 2.5 concentration during, well, it decreased 27% from before the Olympics to during the Olympics. And they had several biomarkers potentially relevant to cardiovascular disease that also decreased. P-selectin is an integrin involved in white blood cells, neutrophils in particular, sticking to vessel walls and then infiltrating into the subendothelial tissue, and von Willebrand factor is important in terms of clotting, thrombosis. So Mesa Air was a very important study. Mike Jarrett and I were both on their external advisory committee, EPA funded. And Mesa was the multi-ethnic study of atherosclerosis. And University of Washington investigators linked up with the Mesa study, which was all over the country, to study the effect of air pollution on an array of cardiovascular endpoints that this Mesa study was obtaining. And I'm going to show you one here. So they looked at carotid intima medial thickness, so-called IMT. And here is, this is using ultrasound on the carotid artery in your neck, a major artery that's easily accessed. And this is a normal carotid artery. And here you can see intimal medial thickness, which represents atherosclerosis. And so you can, with good quality ultrasound, you can, this is a nice objective endpoint of atherosclerosis. And so higher levels of residential PM 2.5 during the Mesa air study were associated with greater IMT progressions. And this is a dose response, or exposure response, I guess I should say. There wasn't much going on. I think this is 3, but it doesn't take much, just 2 micrograms per meter cube difference to see quite a big effect. Again, suggesting that the current standard is not even adequately protective. And this is another study from Mesa Air, and here they're looking at another set of vessels that are readily accessible for epidemiologic studies if you have enough money. And that's retinal arterial diameter. So when the ophthalmologist looks in your eye, they can actually see the size of your arteries, actually sometimes see the atherosclerosis actually, and you can do proper imaging of this and quantitation. And this is showing that as PM 2.5 increases, there is, again, an exposure response with regard to the diameter of your retinal arterioles. You want them to be big, not small. And again, here's 12. So we're learning a lot about metabolic syndrome and cardiovascular disease risk. And metabolic syndrome afflicts people like me. I have a little bit of belly roll here. And hypertension, insulin resistance and risk for type 2 diabetes, overweight, high lipids are features of the metabolic syndrome, high blood pressure. And associations between PM 2.5 exposures and the prevalence of diabetes and diabetes mortality have been observed in the US and Canada. Again, Dr. Jarrett contributed to this literature. Whoa. That's my stuff, sorry. Several studies in the US and Canada have also found that exposure to PM 2.5 was associated with increased risk of hypertension. And several studies have shown association between traffic-related air pollution and obesity. Again, Dr. Jarrett's work. And here is one of these studies. Now, this is in kids, but there's no reason to think that this wouldn't happen in relation to adults. And as a matter of fact, if you're living in a high-traffic area your whole life, which many of us do, this might even progress worse than this. But this isn't particulate matter per se. It's traffic density in a buffer 150 meters around a home versus 300 meters around the home. And these are male and female children in the Southern California Children's Health Study. But there's increased BMI with exposure to traffic in both genders. I guess it's both sexes here. Another study that Dr. Jarrett was involved in, I've already alluded to, was in Ontario. Risk of incident diabetes in relation to long-term exposure to fine particulate matter in Ontario. And there was increased risk. So let me finish up talking about mechanisms, because I'm already getting the 5-minute warning. Air pollution can induce oxidative stress and systemic inflammation, and persistent autonomic imbalance, inflammation with insulin-sensitive, within insulin-sensitive tissues, like fat tissue and liver tissue, altered adipokine expression from adipose cells, and increased stress within each cell have been implicated. And there's actually animal data to show that fine particulate exposure can induce insulin-resistant pre-diabetic state. And this is actually a photo of a mouse from this study. Sorry. The macrophage and then the endothelial cells lining the airways are thought to be the source of the oxidative stress and the original inflammatory signals. This slide also shows the alternative pathway with particle translocation that Kathy talked about for ultrafine particles getting from the alveoli into the circulation. So oxidative stress, various pollutants are capable of generating reactive oxygen species. We're pretty well defended against oxidative stress in our airways because we live in an oxygen environment, 21% oxygen, but the defenses can be overwhelmed, and that's what this slide is showing. And oxidative stress refers to when the antioxidant defense can't keep up with the exposure to reactive oxygen species. And this is just, again, showing that various exposures, which we're talking about today, cause the resident lung cells to develop oxidative stress, which can lead to inflammation. This is sort of the latest and greatest cartoon with regard to possible mechanistic pathways, and I don't have time to go through all of this, but this systemic spillover is the classic pathway that people have been thinking about with regard to how lung injury and inflammation spills over to the systemic circulation and affects the heart and other tissues. There's also effects on the autonomic nervous system. And then there's this potential alternative pathway with translocation of particles. Briefly, there's a lot of experimental evidence with regard to PM and cardiovascular outcomes. This is one of the earlier studies that showed that rats exposed to, and this is PM10 by the way, not PM2.5, actually had increased atherosclerosis, which all of these slides show. This is a atheroma or plaque. And this is just showing the quantitative data from this study. This is a study showing that long-term exposure to PM leads to decreased brachial artery flow-mediated dilation. Kathy already mentioned vasoreactivity. I'm sure that Suzanne Schick and probably Pune are going to talk about this outcome as well, but it's been shown with ambient exposures as well as experimental exposures, which I think they'll talk about. This is a study showing that the bad cholesterol, the low-density lipoproteins, are increased when there's increased exposure to PM2.5, specifically black carbon. This study from Belgium, they actually had people expectorate sputum and looked at their macrophages and showed that the carbon loading correlated with low-density lipoprotein levels. There are, from the same group, they've studied prothrombotic changes in persons with diabetes, and there was an effect on platelet function, platelets being the cellular component of clot, and the magnitude was big. It was as much as 2/3 of patients with cardiovascular disease take antiplatelet medications to prevent MI and stroke, and it was 2/3 of that effect. And this is an important study, though I wouldn't have been able to do this in the US. This is a Swedish study where they exposed individuals with coronary heart disease, ischemic heart disease, to 300 micrograms per meter cubed of diesel exhaust or filtered air, and they actually showed ischemic changes on EKG with 15 minutes of exercise. This is actually more relevant to occupational level exposures than ambient exposures. Heart rate variability is a marker for that autonomic imbalance I referred to. And the idea here is that inhaling particles that induce oxidative stress, inflammation, injury in the lung lead to stimulation of irritant receptors that affect cardiac autonomic balance. There's a lot of data in support of this. So, because I just got the 1 minute slide, epidemiology evidence that ambient PM contributes to cardiovascular disease continues to grow, and we're showing data that suggest that our 12 microgram per meter cubed annual average is not adequately protective for most susceptible members of the population. We're increasing our mechanistic understanding, and there's 3 pathways: the spillover of lung inflammation and injury into the systemic circulation, autonomic nervous system stimulation, penetration of particles directly into cardiovascular tissues. And I haven't had a chance to review this literature, but there are data to show that reductions of ambient PM can improve public health through reduced risk of CVD, cardiovascular disease. This comes from smoking bans and from coal burning bans in various cities around the world. And my last slide is just to mention prevention. And Kathy already said this. You know, but prior to 2 decades ago, we worked with traditional risk factors, and we tried to prevent cardiovascular disease by working on these. But I think over the last 2 decades, we now know that there are other so-called non-traditional risk factors that play an important role. And the article that I took this from estimated up to 30% of the population attributable risk from cardiovascular disease is subsumed in this category, which air pollution, occupational exposures, secondhand tobacco smoke make up. So with that, I'll stop and see if there's any questions. Thank you.
Given, I'm Hattie Hanley, and we've talked about the fact that in Sacramento we have one of the worst air basins in the country, and we're seeing that Sacramento County has the 2nd highest rate of hospitalizations due to myocardial infarction. Could you talk about, from a clinical perspective as a physician, what you can do for your high-risk patients in those high particulate environments to reduce their chance of a disabling or deadly event?
Yeah, it's a very good question. I would start at the macro level. I think it's, as the physician member of the California Air Resources Board, we have to have policies in place to try to lower the exposure, and we have those policies in place, to certainly motor vehicle sourced particles. There are other sources of particles as well. For individual patients, the most important thing is for them not to be outdoors exercising on a, what we call here in the Bay Area, spare the air day. I think Sacramento may have a different designation. Because there are acute effects. But the chronic effects, it's harder to do something about, other than I don't think it would be advisable for someone with active coronary heart disease to be living close to a major roadway. And if they do live close to a major roadway, I would probably recommend installation of a HEPA filter device. So, you know, as somebody who's into occupational environmental health, I'd like to step back and prevent exposures to start with, but when you're dealing with individuals, there's not as much that we could do as I would like. Any other questions?
Maybe a follow-up on that. You see a lot of people in Beijing wearing masks, and I used to scoff at that. You're not going to remove PM2.5, but has the technology advanced? I mean, can you actually remove with masks that are commercially available?
I'll take a stab at that. I almost responded to Haiti that way, but I wasn't sure I was ready to recommend, you know, masks for folks in Sacramento. But yes, now I can't wear an effective mask because I have a beard and I wouldn't get a seal. But there are N95 respirators that I wear in the hospital, even though it doesn't protect me, but I have to because it's the rule. When I go into a patient's room who's suspected of having tuberculosis, that'll well, So what I'd have to wear, Barbara, is the powered air purifying respirator, which it's a little bit hard to do with patient. But the N95 masks are certified by NIOSH to remove 95% of particles of a certain size.
You can get them at the drugstores.
And you get them in the drugstores, as Kathy pointed out. So,
But most of what you see wearing are surgical masks.
yeah, the surgical masks they're called surgical masks because they are supposed to protect the surgical field from exposures from the surgeon. You know, surgeon coughing on the surgical field. They do not protect the individual. And I always tell my dental hygienist when she's wearing a surgical mask, I hope you know that you're protecting me, but you're not protecting yourself. And N95s are a way to reduce exposure, and there was actually one study done in Beijing that showed reduced cardiovascular outcomes, I forget the specific outcomes, with wearing of a mask. So it's not entirely a crazy idea. But Suzanne.
In counterpoint to that, I would say I've worn a P95 mask while working. You know, like doing heavy manual labor cleaning houses, because I have bad allergies and I used to work cleaning houses. They're sweaty, they're uncomfortable, and there is a respiratory burden to pulling the air through the filter material. It is not something that you necessarily get high compliance with unless someone's highly motivated.
So, is it a quick one, Mike? 'Cause
Well,
you know this literature better than I do, sir.
well, yeah, I'm working on this cohort where we have people that have identified themselves, well, they've been identified through medical records as having one pre-existing condition, COPD, asthma, heart disease. But what's remarkable to me when I look at that data is that almost everyone has at least 2 or 3 of these conditions at once.
That's an important point.
And what do we know about the mechanistic actions on people that are suffering from 2 or 3 different chronic diseases?
That's an excellent question. When I ask about the air pollution contribution to respiratory disease or cardiovascular disease, it's always multifactorial. And we need to learn more about the interactions. But as you know, there are data to show that if you have diabetes or hypertension to start with, you have greater effects from a given PM2.5 exposure. And at least with asthma, we know that psychosocial stress is a contributor to the air pollution impact on asthma. I suspect that's also true for cardiovascular disease as well. It's an excellent point. I'm going to stop us here.